Good evening and afternoon for some people, everyone. This is Ben Knoll. I'm the Director of Patient-Centered Research for the Global Healthy Living Foundation and the CreakyJoints patient community, and also a co-PI for Arthritis Power. This is our monthly webinar that we do specifically to share topics that are of interest to people in the community, especially the patients, participants in Arthritis Power, and also within our collaborative research group, the Autoimmune and Systemic Inflammatory Syndromes collaborative research group that's part of CoreNet. So we're thrilled to have Dr. Fraenkel and Dr. Leung with us this evening to talk about a very important topic that's interesting to a lot of people about navigating pharmaceutical and naturopathic medicine for rheumatic and musculoskeletal diseases. So it's unusual for us to get the privilege of two presenters, but we have that this evening. So we've got Dr. Liana Fraenkel and Dr. Leung, and I'll introduce them separately in just a moment. But a couple of housekeeping things, because there's a lot of people on the webinar and some people will come out off and on, only the presenters will be audible during the presentation. And if you're not presenting, then please mute your line if you could. And then for everyone else, the chat or the question window will allow you to post questions during the session. And then at the end of the presentation, we'll take some time to go through the Q&A. So with that, I'm going to go ahead and introduce, first I'll introduce Leung, who will be presenting second, actually, but just so you know who she is. Leung is an assistant professor in the Section of Rheumatology at the Katz School of Medicine at Temple University. Her research studies have focused on epigenetics and systemic lupus erythematosus, and she's expanding her interest to incorporating integrative medicine approaches into rheumatology practice and teaching. She's a recipient of the Jones Level Scholarship in Integrative Rheumatology at the University of Arizona Center for Integrative Medicine. So excited to hear more about that. And Dr. Leung has both an MD and a PhD. But first we'll start with Dr. Liana Fraenkel, who's an MD and PH, a frequent collaborator with us in Arthritis Power and CreakyJoints. She's currently Professor of Medicine and Associate Program Director in the Section of Rheumatology at the Yale School of Medicine. She's Section Chief of Rheumatology at the VA, the Connecticut Healthcare System, and the founder and co-director of the VA Bone and Joint Center. Her clinical practice focuses on caring for patients with systemic inflammatory conditions, including rheumatoid arthritis, psoriatic arthritis, lupus, and other connective tissue diseases. And her research interests lie in developing improved methods of risk communication and decision-making. And we are very excited to have had the honor to get to work with Dr. Fraenkel on several projects in RA shared decision-making. So with that, I'm going to turn it over to you, Dr. Fraenkel.
Thank you very much. So welcome, everybody. So we're going to start with the first part of the talk, which will be on pharmacologic treatment of rheumatoid arthritis. And I know many people are interested in a more broad spectrum of diseases, but it's difficult to cover all of them in one talk since they differ quite a bit. And so we'll use rheumatoid arthritis as an example. So as you know, to care for chronic disease, many different types of treatments are involved. And what we're going to do tonight is we're going to focus on this one part of the pie, which doesn't mean that it's the most important, but we're tonight going to focus on disease-modifying drugs for the first part of the talk. So many of you might be familiar with the original pyramid that was used to guide treatment for rheumatoid arthritis. And a little while ago, we used to start with aspirin in quite high doses and add some anti-inflammatories like Motrin, ibuprofen, which are still in use today, and then eventually get to a disease-modifying anti-rheumatic drug, or as you see here, a DMARD. Way back when gold was used, is still used in some places. It's a very effective medication, but now the mainstay initial DMARD that we use is methotrexate, and many of you, I'm sure, are familiar with many different classes, which we'll go into a little bit as the talk progresses. So the biggest reason that we have flipped the way we now think about rheumatoid arthritis is because several investigators began to show that the earlier you started treatment and the more aggressively you tried to temper down the inflammation, the better people did. And this is sort of an illustrative graph. So as you can see here on the y-axis, this is the radiographic score, and this shows basically how many erosions people have, and higher numbers are worse. And the y-axis here is just time in months. And so people who are treated early, in this line here with the darker line with the squares, what happens is they get treated early and their erosions, their x-rays stay okay. They don't progress very much. But if you delay treatment, and then what happens is those patients kind of progress more rapidly and they never catch up. So that is the big take-home lesson for many of these trials, that even if you delay treatment for as much as 3 months in some studies, you can accumulate damage that is irreversible. And that started making people think about really treating this disease much earlier. So the points underlying that new approach was that joint damage happens early. Much joint damage is unfortunately irreversible. Now, not all patients feel this joint damage. These are largely radiographic findings. It doesn't mean your fingers are in any way changed shape, but this is what we see on x-rays. But also importantly, the duration of disease is inversely proportional to how well patients respond to treatment. So that means the earlier we treat, the more likely you are to respond to that particular medication. So that's also a very important point to think about. So now how we view rheumatoid arthritis, we have actually flipped the pyramids. So instead of starting slowly with aspirin and Motrin and then eventually getting to the disease-modifying anti-rheumatic drugs, now we start with disease-modifying anti-rheumatic drugs as soon as the diagnosis is made. And there is really a lot of effort to have patients seen much earlier. So there's education efforts in the US at the Arthritis Foundation and others have promoted to get people to get to their rheumatologist early. In many countries, there are clinics devoted to early rheumatoid arthritis clinics to make sure that we treat this disease as early and as effectively as possible. And not only are you start on DMARDs, but after that, you're carefully monitored, and we change and add DMARDs to sort of make sure that we control inflammation as well as possible. On the side here, you can see that other therapies besides the DMARDs remain very important in the treatment RA. One is bridging therapy, and I'm sure that many of you heard from your rheumatologist that these guys take a while to work, and so there are different ways to help you while these things start working. And bridging therapy, probably the most common, is prednisone, but sometimes joints are injected, anti-inflammatories can be used, etc. And on this side are non-pharmacologic treatment approaches, which are also very important in both helping with the inflammation as well as the non-inflammatory symptoms. So the model now is to start early and then to treat to target. And I alluded to this just in the slide previously by saying that we want to make sure that we continue to control inflammation as well as possible. And so we think about rheumatoid arthritis now much in the way people treat their diabetes or their high blood pressure or their high cholesterol. We want to get a patient's rheumatoid arthritis down below a certain level and keep it at that level, just like you'd want to get your blood pressure below 140/80 and keep it at that level. So if you see here on the left side of the slide, when somebody presents with the symptoms of rheumatoid arthritis, the goal is to get them early and then start treatment, and then to keep reassessing them and get them under control as early as possible with these disease-modifying drugs to reach their target. And people might be thinking about what is target. I'll talk about that in 1 minute. And once you're there at that target where sometimes I draw graphs with my patients, you want to stay under that line, we reassess on a less frequent basis to make sure people stay where they need to be and where they're happy. So the word target is interesting, and we're not quite sure how to define this. Where is the best place to be? For now, people think about this as either having low disease activity, which generally means 1 or 2 swollen joints, not much more than that, and really very little pain. You just have a touch of rheumatoid arthritis activity going on. Or the target might be complete remission, where you really don't feel like you have rheumatoid arthritis. You feel what patients would refer to as being normal. Like you just don't think about your disease, albeit you are taking medications. And so currently that is what we define as target, although there is quite a bit of activity in people's research programs to define what the target should be. And we know that people who reach a target of remission and stay there do better than people who reach low disease activity. So all this really is to emphasize early, and we use the term aggressive. I don't know if that's the best term, but early and effective treatment to minimize inflammation is very important in the short term to get things under control and to minimize any damage and to improve long-term outcomes. So we talk about long-term outcomes, things like having less surgery in the future, less heart disease in the future, and for sure less deformities. And because of this, what we've seen from this changes in paradigms, we've seen people have less damage. You know, we see many fewer patients now with rheumatoid arthritis who have any crooked joints at all. We also see less disease outside of the joints. So rheumatoid arthritis can unfortunately involve your eyes, your nerves, your lungs, your heart. We see much less of that now because the disease is much better controlled. And there is some early data now showing in more than one study that the number of joints being replaced is less since we have flipped that pyramid. So here's an example of what's happening with these other long-term complications of rheumatoid arthritis. This is on the y-axis is how many people are getting cardiovascular disease. So that's heart disease and stroke. And you can see here basically the people who are on DMARDs, their incidence of these outcomes is much lower. And this is actually only with hydroxychloroquine or Plaquenil. With our biologics, these graphs are separating much more. So this kind of treatment is important not only for the joint swelling, the joint pain, but it's also very important for heart disease, which is a higher risk in rheumatoid arthritis. So these are the current DMARDs, and treat to target and effectively reducing the amount of inflammation people have is in large part possible because we have an explosion of treatments coming on board now for disease-modifying agents. So I don't want to date myself, but when I started, this was the only one available. I can't kind of believe I'm admitting that out loud. And now we have all these available, and I can tell you that these boxes here are going to be filled up probably within months. So every few months there's another drug that's presented to the FDA. There'll be more targeted synthetic DMARDs available that are sort of narrower in scope and have less side effects, which is good news. And there will be new columns added with completely different mechanisms of action. So really a lot of hope, and people are really starting to think about the word cure, which is really wonderful. But there are things way beyond DMARDs that we think about in terms of treatment. We alluded to the importance of bridging treatment, getting things under control before the DMARDs start working. And sometimes there's one or two joints that continue to give patients problems, and certainly glucocorticoids or prednisone play an important role, either orally or directly into the joint. NSAIDs continue to play a role. A lot of people feel that they just feel that much better when they take Motrin, either when they're flaring or as needed. Non-pharmacologic treatment is very important. I just wrote physical therapy and occupational therapy there, but there are a myriad of them, and they've been shown in well-designed studies to be very helpful. Also, we know that there are other symptoms that are not always well controlled with DMARDs, such as residual fatigue and residual pain that may need further treatment, whether it's pharmacologic or non-pharmacologic. And there are comorbidities that are much more common in rheumatoid arthritis than in the general population, and those need to be screened for and addressed. They include things like depression, osteoporosis, and heart disease, and these are really part of the routine care of patients with rheumatoid arthritis. So there are, frequently asked questions when we think about these sort of myriad of new ways of treating arthritis, and really, you're hearing from your doctors now that they really want to treat this much more aggressively. And so patients frequently have a lot of different questions, and here are just some of the more common ones. So one question we frequently hear is, how can I decrease my risk of side effects? So we know that all medications have side effects. The benefits of these disease-modifying agents by far outweigh the risks. That's the reason they are strongly recommended. But still, we want to think about how we can decrease the risk of side effects. And there are ways in rheumatoid arthritis, and by far the most important, probably besides washing hands, is to get vaccinated. And so vaccines are very important in patients with ongoing chronic disease, not only rheumatoid arthritis, but we really want to minimize any infection that we can. So the by far the most important one is the flu shot, and that's strongly recommended in patients with chronic disease. Regardless of what medications you're on, you can get the flu shot. It's not a live vaccine, so that's really every patient with rheumatoid arthritis should be getting that, unless they've had a previous allergic reaction. This is HBV or hepatitis B vaccine, also recommended in this population. These two are both for pneumonia. There are now 2 for pneumonia that are recommended, so that really decreases your risk of having the most common infection associated with patients with rheumatoid arthritis, whether or not they're on disease-modifying agents. Zostrix is for shingles, and interestingly, now there's a new shingles vaccine, and this is actually very important. So Zostrix can be given to anybody who's on a conventional disease-modifying drug like methotrexate or a Reva, but was until now not recommended for patients who are on biologics, although there are new data to show that it's safer than we previously thought. However, Shingrix is not a live vaccine. So this can be given to people who are immunocompromised and on biologics. It is not yet recommended by the CDC for this population because there are no data. So we hope that this will be available and less risky for everybody with rheumatoid arthritis, regardless of their treatment. And this would obviously extend to other diseases in patients treated with biologics or immunosuppressive drugs as well. But probably we need to see a little bit more data showing that Shingrix is effective in that population. That's why you might hear different opinions about this right now, because we just don't have the studies yet. But this is good news. So what's another possible question? Well, I still need to take other rheumatoid arthritis medications. So some people, for example, are on methotrexate or a Reva, and they're having, moderate disease activity. And the rheumatologist, or you might say, I'm not doing as well as I should be doing. And let's talk about new medications. It's odd that you'd have to continue your medication even though you're starting something new. But the reason we tend to do that in most cases is because the studies that show that patients who continue drugs like methotrexate actually do better. And they do better for multiple reasons. So when possible, it is actually preferable to continue drugs like methotrexate even when you add a biologic. And that's the reason for it. Although clearly in specific situations, that recommendation might differ. Other people ask, can I drink alcohol while taking biologics? The answer is yes. How often will I need to be monitored while taking biologics? This really differs, but the good news about biologics is some of them need to be monitored less often than methotrexate. Not all. So for some people, they'll continue to be monitored with routine blood tests every 2 to 3 months, like with methotrexate. Some biologics are monitored much less often. So there's no really added burden to monitoring for many of the biologics. Well, what happens if it doesn't work? Well, the good news is if you think back to that table that I showed, we really have multiple options now. So there's really a lot of hope, and there's always hope that people will respond to a different class or a different biologic, even if they haven't responded to 1, 2, or even 3. So there's still a good chance of responding if you haven't responded to several of them. So there's good reason to remain hopeful that you're going to get your disease under control. And lastly, and I know of a real concern to many patients with rheumatoid arthritis who have a lot of copays to deal with for the anti-inflammatories we talked about and all the other medications they take, is, can I afford this? So this continues to be a very big problem. There are many different groups, including Global Healthy Living Foundation and CreakyJoints, that are really strongly advocating to make sure that biologics are affordable and there's access to these treatments. The American College of Rheumatology and Arthritis Foundation are constantly lobbying for this as well. So it's well recognized that this is a problem. People worry about this every time they change jobs or every year when their insurance is renewed. Well recognized and a strong priority for all patient advocates. And so far we've had quite a bit of luck in keeping things covered and not having biologics escalate to tiers that are out of reach for patients, but that is clearly a very well recognized concern. So I will stop with the last slide just to remind people that we know we all worry about the side effects of medications. We always consider that when we're weighing pros and cons. But what's also important, and I frequently talk about with my patients, is to think about when you're weighing whether to take a medication, to not just think about staying with the status quo, but to remember that there are some very important side effects of leaving rheumatoid arthritis untreated, as we talked about right at the beginning of this talk. So I will now hand over the microphone for the second part of the presentation to Dr. Leung.
Thank you.
Hopefully.
Show my screen. All right, hold on. Let me.
And while we're switching over to Dr. Leung, I'll just remind people that we will have some Q&A at the end. So if you have questions on the presentation so far, please put them in the chat window, and then we'll have an opportunity to hear from both Dr. Fraenkel and Dr. Leung, so we get kind of the whole perspective at the end about pharmaceutical and integrative medicine, about responding to some of these questions. So with that, we'll continue with Dr. Leung. Thanks.
Okay, can you see my screen?
Yep, looks great.
Okay, great. All right, so I'm a academic rheumatologist, and I've been incorporating some integrative medicine practices for my patients. So some of the principles of integrative medicine are that all factors that influence health, wellness, and diseases are important in the healing process. The core areas of health include nutrition, sleep, environment, relationships, movement, spirituality, and resilience. The appropriate use of both conventional and alternative methods facilitates the body's innate healing response. So effective interventions that are natural and less invasive should be used whenever possible. And integrative medicine neither rejects conventional medicine nor accepts alternative therapies uncritically. So good medicine is based in good science, and it is inquiry-driven and open to new paradigms. And we emphasize practices with low risk of harm and that are supported by evidence-based data. So alongside the concept of treatment, the broader concepts of health promotion and the prevention of illnesses are also paramount. So for example, in the treatment of RA, of aggressive RA, I would definitely start early and treat to target, just like Dr. Fraenkel said, with the pharmacological therapies. And at the same time, also emphasize and implement dietary changes, supplement and movement therapies, and so lifestyle changes for the patient. And then perhaps after months or years, after the disease is well controlled, maybe we can try to taper down some of the medications while continuing the lifestyle changes. But these are only, we wouldn't taper or change any medications if the disease is not well controlled. Okay, so the use of complementary and alternative medicine in the US have been increasing, and the data show that approximately 38–40% of adults are using complementary and alternative medicine in some form. And the most frequently used conditions are listed here. And as you can see, the top 4, back pain, neck pain, joint pain, and arthritis, are all problems that are addressed in the field of rheumatology. So there are many different modalities for complementary medicine, and we really don't have time to cover most of them, but I would like to focus particularly today on diet and nutrition influences on inflammatory joint diseases, and then switch gears a bit and end with a short discussion on acupuncture. So when looking at the modern American diet, more than 75% of us are below the recommended goal for consumption of vegetables, fruits, dairy, and healthy oils. And these are foods that are very important because they contain the most nutrients. However, we are far above goals for the consumption of sugars, saturated fat, and sodium. So the consumption pattern of refined sugars have risen dramatically over the centuries. If you look at the annual per capita sucrose consumption in the 1700s, it was only 6 to 8 pounds, and then up to 25 pounds in the 1800s, and a staggering 120 pounds in 1950s, and probably even more, much more now. So, for example, how people are maybe consuming excess sugar is just drinking 1 can of soda or even sweetened teas or juices daily can really add up over time. And 1 can a day can equal to approximately 30 extra pounds of sugar over a year. And I really emphasize this to my patients because a lot of them drink much more than that. And that's a whole lot of empty calories that contain no vitamins, minerals, or micronutrients, and then also decreases overall micronutrient intake by 15%. So in general, the healthy plate should be more than half vegetables and fruits, with the majority being colorful and varied vegetables, and preferably fruits that are high in antioxidants, such as blueberries, blackberries, raspberries. Sugary drinks should be avoided, and whole grains are recommended over refined grains. And then healthy and fresh proteins rather than processed meats are also recommended. So one of the most studied dietary patterns is the Mediterranean diet, which is a diet rich in fish, fruits and vegetables, and low in saturated fat, and also with wine in moderation, particularly red wine. So the Mediterranean diet has been associated with many healthy benefits, including improved cardiovascular profile and benefit in inflammatory joint diseases. And it really forms the basis of the anti-inflammatory diet. The phytonutrients in berries, cocoa, tea, and fresh vegetables may play a meaningful role in reducing cardiovascular disease risk, as well as having modulating and decreasing inflammation. Extra virgin olive oil has been shown to decrease a range of cardiovascular risks, such as improving the lipid profile, and then preventing oxidation of LDL, and as well as improving inflammation. So, and then furthermore, polyunsaturated fatty acids also have been shown to have beneficial effects on cardiovascular risks, as well as markers of inflammation as well. So other things such as fiber have been shown to have both systemic and local intestinal anti-inflammatory activities when they examined plasma inflammatory markers and tissue inflammation. And then magnesium, higher levels of magnesium, which comes from fresh fruits and vegetables, and as well as grains and legumes, can also independently reduce inflammation. So many foods in the Mediterranean diet have been shown to have anti-inflammatory effects, and there's data showing that they decrease inflammatory markers. these food, and you can go over these individually, but these foods include broccoli, legumes, fiber, whole grain, flax seeds, magnesium, walnuts, and red wine, and particularly for rheumatoid arthritis, where TNF alpha plays a big role. A lot of these diseases have been foods have been shown to decrease TNF alpha inflammatory marker. So there are several studies that investigate the effects of the Mediterranean diet on rheumatoid arthritis, and they all showed to varying degrees improvement in disease activity of rheumatoid arthritis. So I want to particularly go over two of these studies. This study in particular evaluates the efficacy of the Mediterranean diet versus the Western diet. And looks at suppression of RA disease activity. So the patients in the Mediterranean diet group were found to have significantly decrease in disease activity, which is measured by DAS28, as well as improvement in physical function and improved vitality. And then for the control patients using the Western diet, no significant change was seen at the end of the study. And then the difference was only notable in the second half of the trial, highlighting that these changes need to be prolonged and looked at for long-term effects. The second study, I think, is very interesting because it looks at the effectiveness of just of actually sending patients to cooking classes that teach them how to cook a Mediterranean diet versus just giving them a handout that with written dietary information. So, and these were done in a population of social economically deprived patient population, and the intervention group was found to have significantly increased dietary intake of vegetables and fruits, and then improved ratio of healthy fat intake. And then there was found to be improvement in pain score, as well as early morning stiffness measurement, as well as patient global assessment. These classes took about 6 weeks of weekly 2-hour classes, and was perhaps something that could be implemented and could be found to be cost effective for our health system. So then if we look more specifically at some of the individual components of the anti-inflammatory diet, and these things sometimes can be taken as supplements. So fatty acids, ingestion of dietary omega-3 fatty acids have consistently been shown to reduce a number of tender joints and duration of morning stiffness, but these clinical benefits were not apparent until greater than 12 weeks. And the minimum daily dose of 3 grams of EPA and DHA appears to be necessary for efficacy, and it may be possible for the patients to reduce NSAIDs use while on these supplements. One caveat is that unfortunately fish oil is expensive and often not covered by insurance, and compliance may be an issue. So, but for the patients with RA, where cardiovascular disease is a major factor, collateral cardiovascular benefits with fish oil makes it an ideal choice for these patients with RA. So gamma-linoleic acid is an essential fatty acid of the omega-6 series, and clinical trials in the doses of 1,400 to 2,800 milligrams daily show clinically relevant reductions in joint pain, morning stiffness, as well as improvement in patient global assessments in RA. And then perhaps combination with fish oil, omega-3 and omega-6, these two can be provide even greater benefit, and they've been shown to have meaningful reductions in DAS28 disease activity and diet outcome measures. So the recommended supplement form is in borage oil for 1 to 2 grams daily. However, that some of the side effects can include soft stools, diarrhea, and bloating. So another supplement that's been or spice that's been that's had a lot of attention for arthritis is turmeric and its active compound curcumin. It was traditionally used in many cultures for pain and wound healing, and recent studies have shown that it can ameliorate many inflammatory diseases, including rheumatoid arthritis, and it can regulate inflammatory cytokines and including decreasing TNF-alpha. The recommended dosage when you take it as a whole spice is starting at 1 teaspoon with each meal. However, bioavailability is actually quite poor, and if you for inflammatory bowel disease, actually that's okay because it stays in the gut, but in order to be absorbed through the gut, the use of black pepper actually can increase bioavailability by up to 2,000-fold. So for inflammatory joint disease, take turmeric with black pepper. And then finally, polyphenols such as resveratrol have been shown to have benefit in treating diseases that are mediated by TNF-alpha. Resveratrol is a powerful antioxidant that is found in blueberries, raspberries, and peanuts, and grapes, and then in higher concentrations in red wine. However, for patients with RA or other autoimmune diseases taking methotrexate, they should abstain from alcohol, including red wine. But they can safely take resveratrol supplements. So now I wanted to turn a little bit to some people may ask about with all these vegetables and fruits, the concerns for pesticides and the expense. So in what we need to buy organic versus others that is okay. So the EWG produce guide has a list of the dirty dozen fruits and vegetables that we should buy organic, and they include strawberries, spinach, nectarines, apples, peaches, etc. And then the ones the clean 15 that we don't need to buy organic are listed here. So finally, I wanted to touch also on the role of the microbiome, because the role of the microbiome is being heavily studied in inflammatory autoimmune diseases. And in genetically predisposed individuals, environmental factors such as diet can cause dysbiosis in the gut microbiota, and this can result in altered gut bacteria species, and then leading to altered host metabolism and the production of pro-inflammatory metabolites. Then this can in turn promote a pro-inflammatory environment that can perpetuate inflammatory diseases. And I'm sure in the next few years, many more studies will come out specifically looking at possibly the role of anti-inflammatory diet and how it can affect the microbiome, especially in inflammatory autoimmune diseases. Okay, so finally, I'm switching gears now to talk about acupuncture. Just a few slides to briefly touch on this topic, since it is a treatment modality that are used by more and more Americans. So there are a number of studies dating as far back as in the 1970s that demonstrate that acupuncture analgesia is mediated through the endogenous opioid system. And then more recent functional MRI studies have shown that acupuncture can deactivate the limbic paralimbic neocortical brain regions, suggesting that acupuncture analgesia may in part be due to attenuation of cognitive response to pain. And then acupuncture is also has been shown to locally reduce peripheral inflammation, and then can change the connective tissue matrix in the area of needle insertion. One of the most important things is it safe? And most studies have shown that acupuncture is a safe pain management option, especially when compared to alternatives. And then major side effects are rare. In some studies with 60,000 acupuncture sessions, no serious adverse events were found. And then in a larger study, I think this is the largest study involving 2.2 million consecutive acupuncture treatments, found 8.6% of patients reported some adverse side effects, but they were not major side effects, and most commonly were bleeding or small hematomas or pain. So the data for acupuncture and its efficacy for pain, there's more data that for chronic pain, that acupuncture is found to be superior to both sham and non-acupuncture control for chronic back and neck pain, osteoarthritis, chronic headache, and shoulder pain. However, for acute pain, the evidence is mixed. Acupuncture was found to be effective in a large systemic review for post-operative pain, and can reduce opiate use for the post-operative day one. It was also found to be effective for tension-type headaches and migraines. However, it was not found to be beneficial for whiplash pain, herpes zoster, recent onset lumbar pain, or labor pain, even though it's frequently used by many patients. Some other reviews have found some positive evidence for low back pain, but this was also disputed in multiple other reviews. So the jury is out there for acupuncture. I think the data is very mixed, but it's due to its relatively safe profile. I think it's worth a try for interested patients. So that's all I have for now, and we can turn to some questions.
Thanks, Dr. Leung. Very interesting, and I think so it's helpful to see these, or have both of you on, and especially because you both have so much familiarity with patients or people who are living with rheumatoid arthritis and other inflammatory conditions. So I'm going to start with kind of a general question that that relates to some of the questions that people have asked. I guess something that comes up a lot is what is the relative effectiveness of the two sort of types of treatment? So within different biologic medications or DMARDs, we often talk about comparative effectiveness or studying the comparative effectiveness. But I wonder, and we have Dr. Leung, you showed cited a lot of the research about some of the specific dietary components, or things like turmeric and so on. But I guess what I worry about is, as a researcher, healthcare professionals, people see those as equivalent. That taking something that for the diet is going to, because there's no data, at least here in this presentation, that talks about that. So Dr. Fraenkel, Dr. Leung, what are your thoughts about that?
So Dr. Leung, do you want to start? I'll comment after.
Sure. So I mean, do you mean data comparing diets to pharmacological treatments? Or I think that you really can't replace. There's no way you can replace pharmacological treatments with an aggressive RA. So I have, for example, I have patients who have mild joint pains, or if they come in saying they don't have a lot of joint swelling, and if they want to hold off on treatment and they're really adamant against starting pharmacological therapies, I still tell them that, for you to get to the point where you have some elevated inflammatory markers, you're having some joint pains, it took many years of your body to develop a pro-inflammatory environment, and it's going to take a long time for any dietary intervention supplements to change that. So I would tell them that I don't think there's, we should wait, and I don't think it's safe to wait to start treatment, and at the same time we should, start the dietary intervention alongside treatment, and then once everything's under control, we can look into tapering. So I would say it's useful for tapering medication maybe in the long term, but once the patient is, the disease is quiescent, but not to replace therapy, pharmacological therapy.
Yeah, I see it exactly the same way. I loved one of your first slides that talked about all the different components of health. And I certainly would see diet as a very important component of this. If we think about the way to manage rheumatoid arthritis, it's basically what we're trying to do is we're trying to tone down the immune system. So whether you do that with a pharmacologic drug, an over-the-counter drug, or your diet, the end result is the same. It's like it's like when people get freaked out about the word chemical, right? Everything's a chemical. So at the end of the day, we're just trying to, anything effective has to end up decreasing your immune system, which is in overdrive. For now, we don't have a diet that can do that, just like Dr. Leung said, enough. It can have an additive effect. It can certainly help in a lot of different health ways, but it can't sort of rebalance your immune system quick enough to get that inflammation under control and to prevent you from getting damage. And that's as much as we know at this time. I agree. There's also a lot of research going on with the microbiome, and one day, we might feel differently if we can block a very early event that starts off a path of inflammation. But we are more than probably 10 years away from that.
Mm-hmm. Yes.
So a related question then is, I think what's sometimes confusing is that the DMARDs, biologics, are immunomodulators, so they target and interrupt certain specific activities in the immune pathway to address the autoimmune condition. And then if the CAM sort of approaches or dietary approaches are meant to strengthen the immune system, I guess on kind of in my simple head, it seems like maybe those are competing with each other. So will diet ever interfere with the effect of a pharmacologic treatment? And is it safe to take both? What's the best way to work with a physician to understand that, or if we could answer those questions?
Well, I think, in terms of the autoimmune diseases, sometimes the confusion is, it's not that the immune system is too strong, it's that the immune system is dysfunctional. It's attacking, autoimmune, it's your own body instead of the normal defense. So I think that would be the that would be my answer. But unfortunately, our medication wise, we don't have anything that we know how to redirect that deranged immune system. That all we have right now is something that can decrease the immune system, but we do have more and more targeted therapies coming out.
Yeah, but it's also just to clarify, you know, what we would consider non-pharmacologic therapy or complementary alternative therapies can be anti-inflammatory. There are anti-inflammatory diets. Fish oils are anti-inflammatory. So non-pharmacologic measures don't necessarily promote the immune system at all. So they don't necessarily, and they shouldn't be assumed to compete against each other. Diets that are new and unstudied, we don't know, you know, but the turmeric, for example, I mean, the complementary alternative medicines that have been promoted for inflammatory arthritis have been shown in some cases to have some evidence of being anti-inflammatory. The question is whether they're anti-inflammatory enough. It's very important to know that when we talk about a DMARD that I mentioned at the beginning, that means that that drug has been shown to modify the natural history of the disease. So it not only controls pain and inflammation today, but it decreases the bone damage, it decreases deformities. And we don't have any data today that diets or turmeric or acupuncture can do that. So that's why it's, you know, they're a wonderful addition. But that's why I think Dr. Leung said they can't replace, as of today, we don't have anything that can slow down, that's been shown to slow down the disease. And that's a major difference. That's a very important to the long-term health of patients.
Right.
Okay. So a question then back to kind of the early part of the presentation. Does it mean that the drugs, you know, DMARDs that someone is taking need to be taken for life, or are there ways to, are there alternatives to maintain, you know, the sort of remission, low disease activity, yet not feel dependent on the drug? And that's a question from one of our listeners.
Do you want me to?
Yes,
go
ahead.
first? Okay.
Yeah.
So that's a really hot area of research. It used to be thought that they needed to be taken for a long time. I never like to say for life, but for a very long time, let's say, because there was really no evidence that we could, you know, as Dr. Leung said, sort of get the immune system back to a normal state, a normal rebalanced state. However, the paradigm is shifting, and there are data that have shown that that are hopeful that if you catch it early, there might be a reasonable chance that you will be able to maintain remission off of medications. There is no question that has not been that only right now is a chance for patients who are presenting relatively early. If you've had established disease for years, that is probably less likely to happen. But there is, you know, fairly reasonable evidence now that even for those patients, that about 50% can taper one drug and stay in remission. There's less good evidence that you can taper everything. But that is where the field is going. People are really looking into, if you treat this early, can you sort of reset the immune system so we don't need to be thinking of taking drugs long term. But I just want to comment on one other thing you said, which was sort of dependent on DMARDs. So this, to me, the word dependent, I think here is a little bit sort of misleading because of the sort of term, you know, the brands we attach to words. So typically in healthcare, when we use the word dependent, we use it in a way to mean that the body is using something, needs something, and it's not really helping you, right? So we're dependent on pain medications. Those pain medications might have, you know, rewired our brain, and our brain now doesn't work as well as it used to. We're drowsy, we don't feel as much, we may be more depressed, and it's not even controlling our pain as well, right? That is a dependency. You're not functioning as well, and you're not really benefiting. Disease-modifying agents are something much more akin to insulin. or thyroid replacement hormones, or a good diet, right? They're what your body currently is needing to get your immune system to work as well as it can. And without it, your immune system goes back and starts, as Dr. Leung said, attacking itself. Your mechanisms in your body are not turning off the inflammation as it should. So I would say that these are regulatory, and if we can figure a way to reset that, that would be great. But the word dependency, I think, infers that the benefits might not outweigh the risks. Whereas here, it's really, I think of it more like insulin.
What would you say? So I sometimes hear from, sometimes we hear from people, or I see things posted online where someone says, I was able to cure my RA, or whatever, based on, I made dietary changes, I made lifestyle changes, I started meditating. And I guess, how do you respond to that when you hear that? And without necessarily knowing a specific case.
So there are fabulous stories. There are stories of people who got cured with bee stings. There are stories of scorpion stings. I actually believe those because they do actually amazing things to your immune system. All those stories they last for a while and then they revert. So whenever we talk about healthcare with anything, we need to talk about what happens to most people. We have to make recommendations for the vast majority of people. There are fantastical things that happen. People wake up from comas after 10 years, but out of 1 million people, 1 person wakes up. So things happen sometimes we don't understand. That's the beauty of life. But it's, to rely on that would not kind of make common sense, because we have good science to show that the likelihood of not trying to control inflammation with things that really work well to control inflammation results in damage that cannot be reversed. So there are always stories. Sometimes they're real. There are patients who truly had RA and something happened. And that's because our bodies are we don't fully understand our bodies. But we make recommendations on what happens to people, to the vast majority of people that we have studied in well-designed trials.
Right. Yeah, I think we do definitely need trials to look into that. And then, but for the the patients who are motivated and interested to try, I would say again, I'm emphasizing alongside conventional pharmacological therapies, they should try every lifestyle change that they wish to try, anti-inflammatory diet, meditation, Tai Chi. All of that to see if that can help in their healing process, and then they can listen to their own bodies and see if that can really help with perhaps tapering some medicines in the future when their disease is in remission.
So one question that came to me actually before the webinar talks about working with their complementary and alternative medicine specialist. So the CAM specialist suggested a battery of tests, like blood work for metal toxicity levels, parasite detection blood work, etc. So should patients be getting those kinds of tests in addition to the blood work that their rheumatologist does?
So right now, I don't think there's much evidence at all about those other tests, and from both my training as in rheumatology and then my current training in integrative medicine and integrative rheumatology, I don't think the tests that you've mentioned there's much data at all behind them.
Okay, and I noticed we're at the top of the hour. I'm wondering if especially if the two presenters are willing to extend just a few more minutes to address a few more questions. This is such an important topic, and if not, it's fine, and we might follow up with some questions and then at least post some responses. But if you have a few more minutes, we'll address a couple more questions. Would that be okay?
Sure.
Yeah, so I'm here.
So there's a couple of questions about vaccinations, and I wondered if we could just talk about those for a second. Are there, so for example, is it true that patients who are on a biologic and other DMARDs who have already had shingles cannot get the vaccine? Or, and this is again a question from Shelley, one of our audience members today.
Yeah, hi Shelley. So there's a couple things going on in that question. So if you've had shingles in the past, you can still get the vaccine. If you're on the conventional DMARDs like methotrexate, Arava or leflunomide, sulfasalazine, hydroxychloroquine or Plaquenil, or any combination of those, you can get the vaccine. If you're on a biologic, then like rituximab, infliximab, etc., then current guidelines recommend that you do not get the vaccine. There are several studies, however, that show that it may be safe. So while there certainly aren't guidelines recommending it, in certain individual situations, it would, I would not be surprised if some rheumatologists are offering it to their patients, especially if they're at higher risk and they've been very well on their biologics and have not had any infections. But currently, the live vaccine is not recommended if you're on a biologic. It doesn't matter if you've had shingles in the past.
Okay, thanks. And then I'll ask one last question, and then we can wrap up. And this is a question, I guess the general question is, if someone's had an allergic reaction or a bad reaction to a particular DMARD, what are their chances of having allergic reactions to others? So I'll read the exact question. This comes from Diane. Just started taking medications, took methotrexate, 2 doses in, I had an allergic reaction. What are my chances of having allergic reactions to the other medications?
Do you want me to answer that one?
Yeah, sure.
Okay, so none, 0. You're at zero elevated risk. So there's a couple of things that I would think about and make sure that things aren't getting confused. So frequently, an allergic reaction is not really an allergy, but an intolerance. That's important to differentiate. It won't matter necessarily for you because you might just not be able to tolerate methotrexate, whether it's an intolerance or an allergic reaction. But you're at no higher risk of having an allergy to any of the other medications.
Okay, great. So thank you so much for this presentation. This is a great topic we may need to revisit on a future webinar because there's so much interest and so many stones to turn. But it sounds like overall the message that you're both sending is that it's very important to focus on the pharmacologic treatment to get disease activity under control, that there is good, diet is helpful as an addition, and especially there's good evidence for the Mediterranean diet, the anti-inflammatory components of that, and that the sort of early aggressive treatment sounds like in the research that's come out in the past few years, it's becoming clear that has the best kind of long-term outcomes to minimize damage.
Yeah, I also, Ben, can I just add one thing?
Sure,
so that
please.
I think we didn't emphasize, but that's really important. Right at the beginning, we both talked about sort of the multi-dimensional ways to treat rheumatoid arthritis. Sleep and non-inflammatory pain and fatigue are really important. Those fatigue is actually the #1 negative factor that influences quality of life over and above pain for many patients. So I think, those complementary methods are much better than any pill for those, and those are very important. So I think that they have as important a role, but just for different purposes. So all those different modalities, whether it's meditation, cognitive behavioral therapy, exercise, sleep hygiene, are super important, right? If those things are not under control, if you're really stressed out and you're really fatigued, your RA is not going to get under control. So there's good evidence for that. So they're really important from the beginning. And I totally agree that if you do, if you exercise and you have your stress well managed and you're doing self-management programs through arthritis, you're much more likely to be able to, maintain a low disease activity or remission state after. So they're truly complementary, but they're as important, but just for different goals.
Yes, thank you for bringing that up. That is absolutely, I totally agree with that. Definitely for fatigue, for fatigue and sometimes generalized pain, a pain syndrome on top of the inflammatory disease, that physical activity, sleep, proper sleep and diet can do so much more than any pill can do. And perhaps we should do another one, focus more on that as well, another webinar, because I would love to talk about sleep and other physical physical activity recommendations.
Great. Thank you so much for your time this evening, Dr. Leung and Dr. Fraenkel, and just for everyone who's attended, thank you for your time. We're recording this, and so we will post a recording and a summary of the session on a webpage on the CreakyJoints website. So we'll send a note out to everyone once that goes up. Thank you very much, and have a great rest of your evening.
Good night, everybody.
Great. Thank you very much. Good night.